Hello everyone, like our previous videos, now this time we're going to start with another new topic, that is healing of wounds. And in this, the 5 major questions are: factors affecting healing of wound has been asked as a 5 marker, biopsy and types of biopsy has been asked as a 5 marker, and then there is exfoliative cytology also, which has been asked as a 5 marker, and healing of extraction wound is also asked as a 5 marker. So there is nothing major like a 10 marker in this chapter, but all minor things that have been asked for 5 markers is what we're going to be dealing with today. So starting with healing of oral wounds. So healing of oral wounds is healing. Firstly, what is healing? We will discuss. Healing is replacement of damaged tissue. So we are replacing the damaged tissue by living tissue. Okay, to restore what? Form and function. Okay, to restore form and function, we are replacing the damaged tissue by a living tissue. So what is repair then? Repair is replacement of lost tissue by granulation tissue. Okay, here we are talking about living tissue. In living tissue, here specifically we are talking about granulation tissue, and repair eventually results in scarring. Now what is regeneration? Replacement by similar type of tissue. So healing is replacement by living tissue, repair is replacement by granulation tissue, and regeneration is replacement by similar type of tissue. Now when the edges of the wound are approximated, healing process fastens. Okay, so if the edges of the wound are approximated, healing is faster. So first healing, that is done with the approximation of the wound edges, is known as the primary healing. So when there is a tissue loss or wound edges cannot be opposed, wound contracts and reduces in size, then granulation tissue fills the wounds, then epithelialization occurs across the wound surface, then healing is by secondary intention. So if there are primary healing, that is the borders of the wound can be determined, then it will heal rapidly, and that is your primary heal. If the borders cannot be determined or the edges cannot be determined, then what happens? The wound first initially contracts, then the edges are formed, then it similarly heals. That is called your secondary healing or secondary intention. So that is how primary healing and secondary healing works. Now coming to the factors affecting wound healing. Now this has been asked as a 5 marker, so please pay attention. What are the factors affecting the healing of wound? First is the physical factors. So what are the physical factors? First is the location of the wound. So location of the wound is where the wound is situated. Like if it is a superficial wound, it will heal faster, but if it is a deep wound, it will take time to heal. So the first factor in that, the broad category, is the physical factors. In physical factors, the first factor is where the wound is located. Okay, the important factor, it is to modify the rate of healing. Wounds in the area of good vascularity can heal more faster, and if there is low vascularity, then they will take time to heal. Then coming to the immobilization of the wound, it is an important in healing. If the wound is at an area subjected to constant movement, then the formation of nerve connective tissue is continuously disrupted. For example, the corner of the mouth. So since there is a wound in the corner of the mouth, continuous is subjected, if the wound is continuously subjected to movement, then there won't be a formation of connective tissue properly, then the wound won't be able to heal faster. So the location of the wound is important, the vascularity of the wound is important, and the mobilization of the wound is important. So 3 factors we learned in the physical factors is the location of the wound, the vascularity of the wound, and the mobility of the wound. Now coming to this trauma, if the wound is having rapid wound healing with mild traumatic injury, then healing increases. Basically, if there is more trauma, less wound healing, less healing process is reduced. If there is less trauma, then healing process is fastened. So that is what it is saying. Depends on the trauma is inversely proportional to healing. Okay. Next is the local temperature. So first was your location, vascularity, mobility, and your trauma. Next is your local temperature. So temperature in the area of the wound influences the rate of healing. Okay. So the rate of healing is influenced by the wound. Okay. So if the wound is in an area where there is a good blood flow and circulation and hyperarrhythmia, then wound heals faster. That is, hyperarrhythmia is basically redness. Okay. If the wound is at a cooler temperature of the body, then there is vascular supply is slow, then the wound heals slowly. Okay. Now coming to the radiations. If the wound is subjected to radiation, high doses of radiation will decrease the healing, low doses of radiation will increase the healing. Okay. Now coming to circulatory factors. Circulatory factors, we have anemia. Anemia delays healing. Obviously, we talked about vascularity so much. Then in anemia, if there is a loss of blood, okay, so anemia delays wound healing, as we discussed prior also, that blood supply or circulation is very necessary for a wound to heal properly. Then coming to dehydration, dehydration also affects wound healing adversely. There is a loss of volume in blood because there is a loss of fluid, because there is dehydration. Then dehydration will also affect the wound healing. Coming to nutritional factors, if there is any malnutrition or any nutritional deficiency, for example B12 deficiency, then the wound won't heal faster. Okay. Then coming to the nutritional factor, in which the major factors are discussed, like I gave you an example of a vitamin. Here everything is taken in account. First is your protein. If protein deficiency is there, there is a delay in appearance of new fibroblasts, okay, which then decreases the rate of multiplication of fibroblasts. Then there is methionine, that is hypoprotein, that is animals, which restore wound healing. So methionine is a protein which restores wound healing. Okay. Then vitamins. So in nutritional factors we discuss protein, vitamins, and vitamin is also an important factor which delays wound healing, as I gave you an example of B12. Then there is an example of vitamin C, that is your scurvy. In scurvy there is a deficiency of vitamin C which inhibits wound healing due to interference with the production of mucopolysaccharides. Okay. Then vitamin A also retards healing. Okay. Then coming to age of the patient, in younger patients healing is rapid, and in older patients healing is slow. Obviously with age healing decreases, and in young adults healing is increased. Okay. Next is your infection. If there is any superimposed infection, then also there is a slow healing. If resistance of the host is decreased, the bacterial flora can also become opportunistic, obviously. Then there is a hormonal effect. In this you just need to know that cortisone delays wound healing. Okay. Then there is diabetes. In diabetes also there is retardation of wound. In diabetes also the wound heals very slowly, and due to which there is a disturbance in carbohydrate metabolism, because of which, okay, there is a disturbance in carbohydrate metabolism. Next is your miscellaneous factors such as your enzymes, trypsin, streptokinase, alkaline phosphatase. Then growth promoting factors such as mucopolysaccharide, glucose aminoglycans, tissue extracts from cartilage. Then trace elements, in that you have your zinc, copper, hydrogen. Zinc basically is essential for DNA synthesis, copper is essential for collagen linking, hydrogen is essential for ion concentration. Coming to the drugs, anti-cancer drugs are anti-cancer drugs, immunosuppressants and anticoagulants can delay healing. Okay. Then coming to your biological and pathological status, antigen antibody reactions occur and if that is antigen antibody reaction is quick, then healing is improved. And yeah, that's pretty much it. You do not need to know anything else. So that is the first 5 marker that we completed, that the factors affecting healing of wounds. So in that you have physical factors, then you have nutritional factors, you have temperature, then you have age, infection, hormonal, and then miscellaneous factors. Now coming to another very important topic, that is biopsy. In biopsy we are going to discuss the types of biopsy. That is very important, incisional and excisional biopsy. Then how biopsy is done we are going to discuss. After that, which is a new topic, that is the healing of biopsy wound, how biopsy is taken, and then how the wound of the biopsy from where it has been taken heals. Okay, so that is secondary. Then yeah, so let's start with a primary biopsy. So what is biopsy? Biopsy is removal of tissue from the living organism for the purpose of examination and diagnosis. So when do we actually do a biopsy? Biopsy is done when a patient is affected from a benign or a malignant condition, which could be cancerous, precancerous, to determine the kind of condition the person is suffering from, where it is causing facial asymmetry, trauma to the face, sometimes difficulty in eating, chewing. So there is a lot of problem because of an external outgrowth or an internal outgrowth in the body. So that outgrowth that outgrowth has to be detected as to what it is causing in the body. To diagnose that, we use a diagnostic measure, that is biopsy. Okay, so biopsy is a removal of tissue from the living organism for the purpose of microscopic examination and diagnosis. Biopsy also serves as a treatment option for smaller lesions by excising in toto. Okay, in toto is in small, like a small bit. Okay, for smaller lesions. Now coming to the types of biopsy. So biopsies of two types, incisional biopsy and excisional biopsy. What is incisional biopsy? Some lesions are too large to excise, right? Some lesions are too large to excise initially without having to establish or diagnose. Okay, so there are some lesions which are too large to excise, so you cannot directly excise the whole lesion to diagnose it. That's why we have something called incisional biopsy, where where they are such a nature that excision is invariable. In such cases, so basically in incisional biopsy, a large wound that has occurred, like a large lesion which is difficult to excise without having to establish a diagnosis of such a wound, we cut a small piece for examination. That is known as your incisional biopsy. So basically incisional biopsy is we take a small piece of a large lesion to diagnose, right? That is your incisional biopsy. Diagnosis will determine whether the line of treatment should be radical or conservative. Then what is excisional biopsy? Excisional biopsy is of a small lesion to study for a microscopic study. It is preferred if the size of the lesion is such that it may be removed along the margin of the normal tissue. The wound can be closed primarily. So usually excisional biopsy is done for smaller lesions where the whole lesion is removed at one shot, and the both treatment and diagnosis will occur in this type of biopsy. Or sometimes excisional biopsy is done for a smaller lesion to again diagnose it in further, and it is preferred if the size of the lesion is such that it may be removed along with the margin of the normal tissue if the wound can be closed primarily. So that is excisional, which is done for a smaller lesion, and there is incisional, which can be done for a larger lesion, right? Now coming to biopsy, it should include the surrounding normal tissue with adequate depth of corrective tissue. Okay, So biopsy should include surrounding normal tissue with adequate depth of connective tissue. There are several methods by which material is obtained from a lesion for microscopic study. So there are several methods by which material is obtained from a lesion for microscopic study. So this is basically how biopsy is done, not majorly, but like other than biopsy, how if it has to be dissected or excised, how it is being excised. First is by the use of scalpel. So scalpel is cleanly it removes the tissue and does not dehydrate it. Okay, so scalpel is basically like a blade thing which slowly and carefully cuts a small piece of the damaged tissue. Okay, then surgical removal by cautery or a high frequency cutting knife is used in dealing with vascular lesions or controlled bleeding at biopsy site. Right now laser is also used. So scalpel is used, then there is high frequency cutting knives, laser, removal by biopsy forceps, biopsy punch. So there is punch biopsy, then there is your knife, high frequency cutting knife, scalpel, laser, aspiration through bore needle, then exfoliative cytology. Right now, how biopsy is done. So this is basically the technique of biopsy. So do not paint the surface of the areas to be biopsied with iodine or high colored antiseptic. So we do not paint the surface of the area to be biopsied with iodine or high colored antiseptic, rather we infiltrate the anesthesia. So the first step is we infiltrate the anesthesia, okay, with your we infiltrate the anesthesia solution directly into the lesion, and not directly into the lesion but around the periphery of the lesion. So we mark the borders of the biopsy, and then in the periphery we inject your anesthesia, not in the center but in the periphery we inject the anesthesia. Then we use a sharp scalpel to avoid rearing the tissue. Okay, then after which we remove the border of the normal tissue with the specimen if all is possible, and we use minimal care and we use care not to multilate the specimen. Okay, so we carefully remove the specimen when holding it with the forceps. So first we mark the borders, then in the periphery we insert the anesthesia, then we use a sharp scalpel and cut the tissue and remove the border of the normal tissue. Then care is maintained, then we hold the forceps and remove the specimen. Okay, so basically this, let's just say that this is a PA and we need a sample of the PA. So PA is basically pleomorphic adenoma. Okay, then we make a border, then we insert anesthesia at the border, and then we use a sharp scalpel and cut the border, after which we remove the border of the normal tissue of the specimen by carefully pulling it with a forceps. Okay, so we basically remove this part, then we fix the tissue immediately on removal with 10% formalin. If the specimen is thin, we place it on a glazed paper and drop fixative. Then we put hemostasis, by that is pressure, or we suture the wound. Okay, so that is another 5 marker we finish here, that is biopsy. Now moving forward with healing of biopsy, how biopsy is healed. This is a little complicated to understand but not that hard, I would say. Okay, so that is one topic. Then we will be finishing the healing of biopsy, which is an important topic. It is quite lengthy, but let us take a dig. Okay, so that was for your biopsy. Now we're going to see how after the biopsy a wound is healed, right? So healing of biopsy. So again, as we discussed, there are two types of lesions that have been identified. One is the primary healing and another is the secondary healing, how a wound heals. So by primary healing, the wound heals by primary intention, that is, the healing occurs after excision of a piece of a tissue with the close apposition of edges of the wound by suture. So now if the wound is too big and the edges of the wound cannot be identified, so then the wound is brought near together by in sutures. Okay, so the primary healing is done with the help of excision. After excision, the pieces of the tissue are brought close together by your sutures. Next is the initial hemorrhage. So when the edges of the wound are brought in contact and held in place by suture, the wound is filled with blood. Okay, so once the edges have been brought together in a close contact, so then the wound or the edges of the wound with the suture is filled with clot or blood, then clot, right? Then after that there is acute inflammatory response that occurs, that is within 24 hours of appearance of polymorphs or from the margin of the incision. So once there is the formation of clot, you have your PMNs, your polymorphs. Then by the third day, the polymorphs are replaced by macrophages. Okay. Then the epithelial changes occur in which the basal cell of the epidermis from both cut the margins start proliferating. So epithelial changes occur after the acute inflammatory response. There is an epithelial change where the basal cells of the epidermis from both cut margins starts proliferating. Basically, if this is the your wound, the basal cells, that is the cells lying in the basement membrane, these cells grow near. Okay, they grow in layers, and then there is a formation of epithelial spurt, that is your epithelial basal cells migrate towards the incisional space, forming epithelial spurts. Now migration of the epidermal cells separates the underlying viable debris from the overlying necrotic material and forms a clot. That clot is called scab. So initially when you get a wound, you have this brown color covering over the wound. This type of covering that wards off or casts off with time, that is your scab. Okay, then by approximation, the wound is covered by a layer of epithelium. Once the scab, sometimes when the scab goes off, the epithelial covers the scab. Okay, now organization. By the third day, fibroblasts invade the wound area, and by the fifth day, new collagen fibrils start forming. Okay, so third day the fibroblasts invade the wound, and by fifth day the new collagen fibrils start forming. Okay, and intertwine and coalesce in a direction parallel to the surface of wound. Okay, so the organization occurs in the third day. Fibroblasts invade the wound, then by fifth day new collagen fibrils are formed, then they intertwine and coalesce to form a parallel surface to the wound. At the same time, the endothelial cells of capillaries begin to proliferate. Now small capillary buds grow out, and across the wound the buds eventually form new capillaries. Okay, then there is a removal of suture around 7th day. It results in scar tissue at the site of incision. So once your epithelial changes occur, epithelial spurts form, then scab is formed, scab wards off, epithelial cells, that is your epithelial layer, covers the tissue, then your fibroblasts invade beneath the epithelium, and then these fibroblasts form collagen. The collagen gets intertwined and it coalesces in a parallel direction. At the same time, epithelial cells begin to proliferate and your capillary formation begins. Small capillary buds grow, then your wound becomes new and new capillaries grow, then your wound becomes vascularized, then there is removal of suture. So around 7th day the suture is removed, and that after the removal of suture the wound results in a scar formation. Because there is no defect in which must be filled with new tissue, this type of wound heals rapidly. So now you can see here that how the wound is healing. First there is your hemorrhage occurring, that is your clot is forming, then all your polymorphs are present near the clot, then the clot is warding off like a scab, then your fibroblasts come in, they lay collagen and close off the epithelium. Now that is your primary healing. Now then there is secondary healing. In secondary healing what happens is, it occurs when there is a loss of tissue edges of the wound and the wound edges cannot be approximated. So in primary healing what we did is, we were able to identify the edges of the wound and then we used to suture it. But in secondary healing we are unable to identify the edges of the wound. The wound is a little big in such a way that we are unable to identify the edges itself. So first is the initial hemorrhage. In the initial hemorrhage, after the removal of the lesion, the blood fills the defects. So in the initial hemorrhage, let's just say that the lesion is very big and the borders of the lesion is not determined. Okay, so the lesion is very big and the removal of the after the removal of the lesion, there is blood that is filling the defects. So basically we are removing the whole lesion and there is a whole space in which the blood fills the defects. Clots repair and proceed to begin and repair process begins. So there is removal of lesion, blood fills the defects, clots repair and the repair process begins. Then there is inflammatory phase, in which initial acute inflammatory responses occur. Same way here also, like it is very similar to the primary healing, only here what occurs is differently is your borders or the edges of the wound are not approximated. So there, after the removal of lesion, there is blood that fills, then there is clot, then the clot is accompanied by macrophages, then epithelial spurs form, they fill the gap, then epithelial cells are forming epithelial spurs. But however here epithelial spurs do not cover the surface until full granulation tissue has filled. Okay, so first your boundary is not approximated in secondary lesion. So there is the same way like how the primary lesion was healing, here also you have hemorrhage, you have lesion, you have the blood filling the lesion, you have repair process, you have macrophages, you have cells of the dermis, and then you have your epithelial spurs. But these epithelial spurs do not proliferate, rather there is granulation tissue formation. Okay, and the pre-existing viable connective tissue is separated from the necrotic material of the clot and scab is formed. Then this scab is casted off, then the granulation tissue proceeds with secondary healing. Same way then the granulation tissue. So the only thing that is extra here is your granulation tissue. Then after granulation tissue everything follows same. The fibroblasts are formed, lymphocytes are accompanying the fibroblasts, then you have your collagen deposition and your granulation tissue maturation, and then the wound contracts. So basically in wound contraction action of myofibroblasts are present in the granulation tissue, occurs when the granulation tissue is being formed. So this is your granulation tissue, hemorrhage is occurring, your PMNs are coming in picture, you have your connective tissue, plasma cells, and there is a formation of scab, and then that leads to the collagen scar. That is about your secondary healing. Now coming to the exfoliative cytology, this is also been asked for 5 marks. This has just the procedure how it is done and the classification of exfoliative cytology. Then we have healing of extraction wound, and I think complications and dry circuit. These are the main important things that we have. So let's begin with exfoliative cytology, and then the dry circuit I'll be dealing with the next video because it is very important. Okay, coming to the exfoliative cytology. Exfoliative cytology is a study of cells that exfoliate or abrade from the body surface. So these exfoliative cells that are scraped off by the means of specific instruments. I'm going to take an example of leukoplakia. So for the identification of leukoplakia, you take a paper or a sheet and then you place it under the wound where the leukoplakia has occurred, and then you take an instrument and scrape that instrument. The cells or the exfoliations that fall are studied and taken as a diagnostic tool. So indications: cytology is not a substitute but an adjunct to surgical biopsy. It helps, so basically it's just a additive diagnosis, not an exact diagnosis. It helps to check against a false or negative biopsy, helpful in follow-ups, and valuable for screening lesions. Now gynecological also, it is helpful in detecting your cervical cancer, respiratory lung cancer, urinary, detecting the urinary infections or malignancies. Then in your body fluids, pleural fluid, peritoneal fluid, cerebrospinal fluid, then your oral leukoplakia, erythroplakia, skin lesions. Here and all you use your exfoliative cytology. Now how is it done? As I told you, you first clean the surface of the lesion, then you vigorously scrape the entire surface several times with a metal spatula or a tongue blade. Then you collect the material quickly, and then you have to spread the material over a microscope on the glass slide and then fix it immediately before smearing. Fixation may be commercial spray, that is your site, that is your 95% alcohol, or alcohol and ether can be used. After the slide is flooded with fixative, it should be allowed to dry for 30 minutes and you do not flame it. This procedure is repeated. In the second smear is prepared, both smears are diagnosed and a result is submitted. Right? Now the report. Cytological smears with regards to provisional diagnosis of the malignancy or pre-malignancy will be reported by a cytologist are following into the 5 classes. So basically what type of cytology it has been classified. If it falls under class 1, then there is normal cells, no pre-malignancy has been noticed. Malignancy is a farther away term. Pre-malignancy is also not seen if it is class 1. Then class 2 indicates presence of minor atypia, but you cannot say that there is any pre-malignancy or malignancy. Class 3, in between cytology that separates cancer from non-cancerous diagnosis. The cells display atypia, that is your suggestive of cancer, but they are not clear-cut cancer. These are your pre-malignant conditions. So class 3, if a cytological report says that it is coming under class 3, that means that they are precancerous. Then next is your class 4, that is malignancy, and many cells show borderline characteristics. Here you have to do biopsy also to confirm, and if it is class 5, then it is definitely malignant. Right? Now there are limitations of these. Also negative cytological report does not rule out that there is no malignancy. You have to still consider biopsy. Limitations: presence or extent of invasion cannot be assessed. Majority of the benign lesions of the ineffective for cytological smears, lesions having normal appearance and intact surface, are fibroepithelial polyps and pyogenic granuloma. Then coming to the healing of extracted wounds, this I am going to deal with in the next video, because you have a full-fledged 10 marker also. Sometimes I have not seen a 10 marker, but it can come as a 10 marker, that is a healing of wounds and the factors affecting healing of wounds. This has been asked in your surgery as well, so oral surgery. So I'm going to make another topic on healing of extracted wounds and its complications. Okay, so for this video this much, and for my next video stay tuned, subscribe to my channel, follow for more. Bye bye.